25 TMA wire, so I can extrude anterior teeth and also extrude posterior teeth as well. And not only help to increase the upper incisor display, also you bring the upper occlusal plane down and also push the mandible rotate downward and backwards. 11 months, now at this moment the lower dental midline was on. And I removed the BioRazor to see whether the result is stable or not. Of course, the result is not stable. So I kept going for that for several times. So I keep the same mechanism, upper total arch extrusion, BioRazor, and intermaxillary elastics. 28 months. I removed the extruded spring and also removed the BioRazor, try to see whether that is stable or not. Of course, you can get the result quickly. Around 6 months, you'll be able to get a good occlusion and good profile. But you are right, everything have relapse. You cannot have relapse. The rest of the treatment will be spending time on dealing with the relapse. The best policy to deal with the relapse is to against it. No, you have to deal with the relapse during the treatment instead of after treatment. After treatment, you only have to retain the how could you deal with the relapse, especially jawbone. So you can see the progress change of her face. You can see actually the result, the improvement of her face actually was there 6 months already. The rest of the time, you can see some relapse. Don't worry about that. Keep doing for the same mechanism until you see a stable result, lasting for 4 to 5 months. Then that is the time to finish the patient. So overall, I spent 33 months. You said that was a long treatment, yes. But in comparison to the price, to the process that we went through for the surgery, I think that is worthy. The change of her profile and smile, I think that was nice. And also look at the upper incisor display, because we purposely bring the upper dentition down. The change of the soft tissue by superimposition looks like she had a surgery because the chin and lower lip just went backwards. And superimposed, you can see upper dentition was actually for 4 to 6 millimeter. The mandible, the lower dentition, posterior extrusion, lower anterior intrusion. And you can see the change, positional change of the mandible. Went backward for 7 millimeter. So it looks like the mandible was surgically set back for 7 millimeter, but no, actually no. And of course, we also care about whether the contact position has some changes. You can see now the left side contact actually have a little bit upward reposition during the process. And that was the reason why you can see this patient. I think I can go back. You can see this patient, the chin deviation actually improved. That means the BioRazor may also can improve the chin deviation as well. And one of the reasons is, this is so. One of the reasons is the contact repositioning on the left side. So left side, the upward repositioning so the chin will move to the left side. So left side contact you can see here. Also from the frontal view, you can see there's an upward repositioning of the contact head on the left side. So you can see the shift of the mandible as well. This is another patient, 21 years old, underbite, crooked face, long chin, but again, asking for nose gel surgery. Intraorally, you see class 3 anterior cord spike, upper and lower anterior crowding. So right at the beginning, you can see right at the beginning, after bonding, when the patient adjusts well, then you can start to put the BioRazor, raise the bite, and then apply for the intermediary elastic. And also lower taste actually was there to help to bring the low dentition back. The change of patient's face. Once you put out the BioRazor, the face change. And patients, they can see it. So they will be very happy to wear the intermediary elastic because they see their face changes very quickly and quite nice. 5 months, upper taste with extruding labor arm to increase the upper incisor display. 13 months, keep going for the same procedure. And this moment, you can see now the dental midline on. Actually, I did nothing for change the dental midline. But since the BioRazor, I said that earlier, that working as a single tooth occlusal spring. So that helped to relocate the contact hair. 13 months, you can see the change of the profile. 28 months. So you can see, actually the result is quite early there already. But I just kept going because I want to see a stable result before I remove the bracket. 13 months. So I removed the spring, removed the BioRazor, but keep using the intermediary elastic when you are observing whether that is stable or not. 35 months, finish the patient. You can see the upper incisor angle, lower incisor angle. Without tooth extraction, usually you will see procline the upper incisor, retrocline the lower incisor. But pay attention and look at the upper incisor angle and lower incisor angle. When she smiles, full upper incisor display. Good facial profile and also the lip thickness maintained quite well. The progress change of her facial profile. You can see the result actually is there quite early. The rest of the time, we have to keep it stable. The progressive change of the chin deviation. So also the chin deviation can be improved by using the BioRazor. The upper incisor display is not quite nice. So actually, if you look at this, if I claim, say this is surgical case, you will believe. But anyway, there's no jaw surgery. So we did a study to look at what are the average change of this kind of treatment. So we have a CT scan, overall superimposed on the cranial base to look at the change of the mandibular posture, position at the Manton, Pogonian, and etc. Superimposed on the cranial base to see the changes of the maxillary dentition. Mandibular superimposed to see the changes of the mandibular dentition. So the overall, you can see for those group with BioRazor, at the beginning, actually, they are more severe patients. The reason why they went for BioRazor because they were more severe than those patients without. And also, you can see the facial convexity, extra things, they were all significant difference. Although, I'm sorry, the improvement of the facial convexity actually was much better. Although the treatment duration was similar, okay, that is the change of the BioRazor group had the more maxillary total arch extrusion and also have more downward and backward of the mandibular posture change. That means the mandible actually went downward and went backward. The backward movement is around 2 millimeters. And of course, when you are extruding the upper molar and lower molar more, the mandible rotate will be more, so that the chin will go back more. So conclusion will be orthodontic total arch extrusion technique with BioRazor and intermediary elastic improve the skeleton facial convexity in adult patients with class 3 malocclusion through backward and downward rotation of the mandible. And don't forget, this technique, of course, can be used for the relapse in surgical patients. In classic patients, if they go for surgery, certainly they're going to have certain degree of relapse. When you see the relapse in surgical patient, use BioRazor to rotate the mandible back. So that would be a very good another choice for surgical patient as well, not only for non-surgical patients. So I give you this patient, 47 years old. I think her face, I would say, looks like older than her age, to be honest. So you can see her upper lip thickness is not good. The upper incisor display is no good. Too much lower incisor display, and the chin deviation and the chin projection is a little bit more than the others. Anterior crossbite, multiple missing teeth, have a right side tear joint clicking, lower dental minor is on. So again, 2 months of the alignment, I put on the BioRazor already. And of course, the lower dental minor still shift to the left 1.5 millimeter. In 2 months, you can see the face already changed already. So patient, they will be very happy because shortly after the start of the treatment, their face improve. Once their face improve, their cooperation will be very good. 3 months lower test to help to bring the low dentition back. 5 months, 1 year. So I keep going for the same mechanism. But the lower left side test dislodged, okay, but the dental minor is on already. 1 year. The further improvement of a younger facial profile. But anyway, patients, she still prefer a little bit slight face, especially the upper and lower lip. So she was asking, hey, I want my lip back more. But then I say, well, if I bring your teeth back, your nasolabial fold will become deeper, your lip may become thinner, which gives you an older facial appearances. But she still insisted that she preferred to have a lip back more. So we put the test back again and keep retracting the upper and lower dentition. 1 year and 9 months. Okay. And lower, of course, we have to try to include lower. And here we use a test to include lower incisor because I want to hide the lower entities as good as possible, show the upper dentition as good as possible. Three years. I spent 3 years to finish this patient. Okay, and let's look at the face. This is pre-treatment, 1 year of treatment, 3 years of treatment. You can see the progress change of her face, and I do believe, I feel like she get younger after the treatment. Okay, that is better upper incisor display and less lower incisor display after treatment. Okay, so you can see after I retract the upper and lower lip, actually the chin projection looks like more. So we have to be very careful when we only retract the lower entities or upper entities. This might give the patient the chin projection worse. So we do have a study to look at the change of the lip thickness after treatment. So we measure the upper lip area, surface area, and lower lip surface area. The results showing that the upper lip surface actually, for those patients who had BioRazor, increased a lot. That means when the upper lip thickness becomes thicker, the patient look younger. When the upper lip becomes thinner, the patient look older. So we have to be careful about not only the lip, the position of the lip, but also the thickness of the lip. And don't forget, we orthodontics, we are able to control the lip thickness by positioning the teeth. So next, I will get into how we can really control and correct or improve the chin deviation. For chin deviation, that could be because of size difference between right and left. Could be because of morphology difference between right and left. Could be because of joint, the TM joint. The mandible could be quite symmetrical, but because of joint displacement, so that the joint deviates to the other side. Or, of course, we know that could be because of occlusion. Okay, so recent year, we have been seeing this a lot. A lot of TM joint specialists, they say when the facial asymmetry patient, they have occlusal spring, and after that, their chin deviation facial asymmetry improved. And this has been studied and reported in several articles. So the problem is how we treated that, the joint occlusal spring. But the question would be, I'm sorry. If we use occlusal spring to treat a facial asymmetry, then we are not able to move teeth. So my idea is to shrink a full coverage occlusal spring to a single tooth only, so that I can move the other teeth. So that would be the same concept. Occlusal spring is to establish a stable occlusion to stabilize the condyle. So again, no matter that is the full coverage or not, single tooth can also open the joint, and then we do tooth movement to establish a stable occlusion to stabilize the condyle head. So that is the whole concept why we are able to use that. So this is single tooth occlusal spring, also called BiRazor. My hypothesis to using this BiRazor is the single tooth occlusal spring open the joint space and repositions condyle and then induce up and down roll rotation of the mandible. Okay? And then I also have another design that is bi-slope. That is a slope in upper and another slope in the lower, and they are opposite. So when the patient they bites, these two slopes will guide the mandible to the direction that you want. Okay? So my hypothesis for this bi-slope will be they're going to induce a yaw rotation of the mandible, because some of the facial asymmetry could be because roll rotation, some of them could be because of yaw rotation, and some of them may be a combination of roll rotation and yaw rotation as well. So I would like to apply these to improve the patient's facial asymmetry if the patient have a condyle displacement. So let me use this class 1 case as an example to show you how we can utilize that. So first of all, we would like to know why the mandible deviated. The occlusion is quite nice, although she had the braces before, but she wasn't happy about the face. It's not symmetrical. So from the CT scan, you can see chin deviate to the left side, and when I analyze the length of the ramus, actually the right side and left side, they are in similar lengths. Because in most of the situations, we believe that it's a jawbone size discrepancy causes the facial asymmetry, but no, this is not 100%. There are many patients out there, their ramus height actually are quite similar, but had a chin deviation. So that could be have something else that caused that much of the chin deviation. The second one, I want to see the body length and also the morphology and geometry of the mandible. Although the geometry, there's a little bit asymmetry, but basically the length of the body, they are equal. that's supposed not to give a 5 millimeter of the chin deviation. And then I look at the contact position. Now look at the position of the mandible. You can see there's a yaw rotation. There's a to the left yaw rotation. So you can see to the right, no, to the left, I'm sorry. So you can see the right side contact actually displays backward and inward. The left side contact actually displays forward and laterally. Okay, because you also have clicking. So this is a very good sign that part of the chin deviation in this patient was because of the contact displacement in this patient, especially yaw rotation. Look at this. The joint space on the left side actually is more at the back. So that shows that the contact head actually displays anteriorly. So if we were able to do another way of yaw rotation to reposition the contact head, then what we will be able to improve the chin deviation without surgery. So pull on the wire, and then for the upper occlusal can, I will use the yin yang wire. So that is the yin yang wire you need. Okay, and looks like this. That is the yin yang wire. I use that to improve the occlusal cant. So and then at the same time using bi-slope, because her main problem of the facial symmetry was because of cant and also the mandibular yaw rotation. So when I use these two bi-slope to rotate the mandible. Then also don't forget the intermaxillary elastic. So just keep on that. And after that, at this moment, I started to use the yin yang wire. And then, of course, you have to observe whether the result is stable or not. Make sure that the result can be there for 4 to 5 months before you remove the bracket. But actually, in this case, I did not. So you can see the changes of her face, and the chin deviation improved after the treatment. This is quite bothering. Okay. So summary of her treatment, she had a yin yang wire for 8 months, and also bi-slope for another 8 months. But here, since we could not very sure that whether the patient only had yaw rotation without raw rotation. So I would strongly suggest you start from bi-razor to have a raw rotation first, and then if the chin deviation stop improving, and then you can change it to the bi-slope, have a yaw rotation of the mandible. So that is her CT scan. You can see the changes of her mandible. The move to the right 3 millimeter. And you can see from the segmental view, you can see there's a yaw rotation of the mandible. The right side contact actually repositioned 1 millimeter posteriorly. And the right side contact head also repositioned 1 millimeter to the right. That helped to improve the chin deviation. And I superimpose on the mandible to see whether there's a surface remodeling going on. So you can see there's a favorable contact surface, superior surface deposition, remodeling 2 to 2.5 millimeter on the left side, 1 millimeter on the right side. That means that also helped to improve the chin deviation. 3 years after treatment, the result remains stable. After treatment and 3 years after treatment, I think the chin deviation remains stable. The occlusion remains stable as well. So I took a CT scan, again, 3 years after treatment, to see why the chin is stable. So when I superimpose them, you can see on her left side, you can see green color ramus, right? That means green color is 3 years after treatment. That means after 3 years after treatment, the left side actually moved forward. The left ramus actually moved forward. Think about that. The left side ramus moved forward. That helped further improve the chin deviation in this patient. So superimpose on the mandible to see whether there's a surface remodeling. I found out there's unfavorable condyle surface remodeling happening. More left side condyle reposition remodeling 2 millimeter than the right side condyle surface remodeling for 1 millimeter. And suppose to have relapse, but she did not have relapse. And this is to see the positional change of the mandible. You can see there's a favorable condyle ramus repositioning happening. So you can see from here, from here you can see the left side condyle actually reposition further forward. And that helped to maintain the result. So we have started to look at the effect of those patients. So the patient for the experimental group, 13 of them, they have, thank you very much. Yes, okay. 13 of them, they have a TM joint problem. So today, you will learn that if you go back to your office, you see your patient have a TM joint clicking problem. For those patients, you may be able to improve their facial symmetry because that means clicking means condyle displacement. So we have it over superimposed, we have a regional superimposed to see the changes. And you can see for the deviated side, you can see there was more inferior and anterior displacement of the mandible, of the condyle, I'm sorry. That means the deviated side had more inferior anterior reposition that helped to improve the chin deviation. So look at the surface remodeling. That is the methodology that we use to look at the surface remodeling. Very surprisingly, both of the group, they both have condyle surface remodeling. You can see intra-group, you can see a lot of significant difference, but inter-group, there has no significant difference. That means no matter the patient have a bilateral or not, they always have a condyle surface remodeling, even though only have the braces. So don't forget, when you put on braces, when we move teeth, usually we'll have condyle surface remodeling happening. And also look at the glenoid fossa remodeling. So that is the methodology that we use to look at the glenoid fossa remodeling. And there's no significant difference of the glenoid fossa. So condyle is easier to have surface remodeling, but not the glenoid fossa. So look at the rotation of the mandible. So you can see most of the time the mandible have roll rotation and also have a yaw rotation. That means the deviated condyle move down and forward. So that induces a roll rotation. When you move down, there's a roll rotation. When they move forward, there's a yaw rotation. So that was the reason why those mandibles can be improved. And we also look at the improvement of the chin deviation. So overall, you can see 1.8 millimeter of improvement. That's around 2 millimeter easier to remember. That means in average, if we use this technique, we'll be able to improve around 2 millimeter of the chin deviation. So now here comes the first clinical implication. Since the chin deviation, in average, we are able to improve 2 millimeter. And second thing is because of chin deviation less than 2 millimeter is hardly can be seen by the patients. For example, if I have a chin deviation around 3 millimeters, of course you will see it. And I am able to improve that, reduce that for 2 millimeters. That means I will only have 1 millimeter left. The patient, they won't see. Maybe you will not see neither. So that is the reason why you can tell the improvement, because within 2 millimeters, the patient will hardly to be seen. So overall, they are 4 millimeters. So for chin deviation, less than 4 millimeters, that means we have a chance to improve their facial symmetry without surgery. So don't forget, those patients of mine, they all have a TND problem. So the second clinical implication will be, if the facial symmetry is because of jawbone size discrepancy, is because of morphology, that means you have less chance to improve that without surgery. If the etiology is because of occlusion, because of joint, then we have a higher chance to improve the facial symmetry. So conclusion of this study, the impact of the bilateral slope on non-surgical orthodontic for mandibular symmetry could be due to a favorable repositioning of the condyle on the deviated side and then mandibular roll or yaw rotation. Of course, this technique, non-surgical orthodontic treatment with or without bi-razor, don't forget, once you put on brackets, the condyle start to remodeling. So the question will be, how should we maintain the result? You see, we have a teeth retainer, right? We have a Holey retainer, we have an SS retainer, we have bonding retainer to retain the teeth. But how could we retain condyle? Does condyle has a retainer? The answer is yes. The condyle has a retainer. Let me show you this case. This is a 49 years old patient with a facial symmetry, class 3. I'll go quickly. She had a tooth movement before, and the plan was going to do upper taste to do thoracic extrusion to increase the upper incisor display, lower taste to do thoracic digitalization, bi-slope and bi-razor for joint and symmetry, put on the brackets, lower taste, and then bi-razor on. Okay, then I'll keep going for that. I will go quickly. Upper taste, actually upper dentition, and then now I change it to bi-slope because it has been 10 months. Her facial symmetry improved a little bit, but not too much. So now I'm using bi-slope to bring the dental minute on to have a yaw rotation. Compared to the change of the face, 21 months. Okay, so until now I still feel good, but the problem comes after this. This profile was nice, 33 months. You see, from 21 months to 33 months. Why is that? Because I keep having relapse. The chin keeps relapsing back. So you can see little by little, the lower dental midline off to the left side. 0.5 millimeter face, you can see a little bit of chin deviation now. 36 months. You see the lower dental midline further off to the left side, 1.5 millimeter. But because of 36 months already, and I asked the patient, should we keep going or not? She said, no, enough. Let's finish it. So I finished her at 37 months. But you can see dental midline was not on, and the face still have a little bit of chin deviation. But in comparison to before, I think that was a good improvement, although not perfect, but could be quite acceptable. And the CT scan, okay, you can see the left side condyle, I did a good job to have an inferior repositioning of the left side condyle. But 1.5 years after, she came back to me and had a further dental midline off, and she was complaining of TM joint clicking, TM joint pain. She was complaining about the chin deviates again. So she was like this. Okay? So what are you going to do? So before I make decision, I took the CT scan and said, okay, I want to take the CT scan. I'm going to make sure that what happened then before we can go further. So that is CT scan showing that, yes, the mandible shifted back to the left a little bit. And when I have a comparison of after treatment and 1.5 years after, you can see obviously the right side condyle have an inferior and anterior displacement. Okay? The left side condyle have no obvious displacement. So here I know that the problem is on the right side condyle, head. Okay? And in terms of pitch, class 3, they have a little bit of relapse, which is acceptable. Okay? So the question will be, could we reposition the right side condyle head back so that I can put the chin back? So, again, when we reposition the condyle, what we're going to do is occlusal sprint. Okay, so either I can send my patient to a TM joint specialist to ask the TM specialist to have a occlusal sprint for her. Or because I'm an orthodontics, are we able to give her something very similar to occlusal sprint? The answer is yes. So you can see the design is this SS retainer. I have the resin, bi-razor inside to open up the joint again, or I can put bi-razors on Holy retainer to open up the joint. So the answer for what is the retainer for condyle? Occlusal sprint or bi-razors. Oh, I'm sorry. So this is immediately, when I put on the SS retainer with bi-razor, you can see immediately I put it on, only in upper. Okay, I ask the patient to wear this when she sleeps. So once I put it on, I ask her to bite. When she bites, you can see the denominator almost on. The clicking gone. And then she was happy. So I have an appointment with her 3 months after. She didn't come back. So I asked my assistant, call her, ask her to come back. And she answered, I'm okay now. I'm quite happy with that retainer. And I'm a teacher, I don't have time to go back. When I have problem, I will go back. Until now, she haven't come back yet. Okay, so take home message, apply bi-razor and intermesh elastic for the intermediate class 3 profile improvement in the beginning of the treatment or as early as possible. The current practical line is a clinical chin deviation within 4 millimeters could be possibly improved by non-surgically by using bi-razor or bi-slope. Removable retainers with bi-razor could be a good option for retaining the condyle repositioning in class 3 or mandibular symmetry patients. These are the messages that I would like to, that you have. And I hope these messages can help your practice and also can help you out in some of your trouble cases. Thank you very much.
Thank you, Dr. Eric Liu. It was a great lecture from you, and you have really expanded the horizon of orthodontics, especially you have gone into the surgical orthodontics. So we put on record your all efforts in the science of orthodontics. Thank you very much. Please come to receive the certificate of appreciation from Indian Orthodontic Society.
Thank you. Thank you. Thank you.
It was really a great work done by you.
Thank you. Oh. Yeah. Thank you.
Nishi. So we'll now be having an interactive session led by OrthoFX. Now I call upon Dr. Girish Karandikar, sir. No, sir. I'm extremely sorry, sir. Sir, can I request Sanjay Lab, sir, to please stay over? I'm extremely sorry. I request Dr. Silju, sir, to please give the certificate to...
Do I?
Sanjay Lab, sir.
Lane cable?
I request Girish Karandikar, sir, to please take over for the next session.
A very good afternoon, ladies and gentlemen. If we consider that any brand of fixed appliance, any type of fixed appliance is akin to a test match in cricket, we know that we always like to have options of watching the 50-over game, which is what probably the clear aligners represent. And just as after 50 overs game has come, even shortened game of T20, so there is a product which Indian Orthodontic Society has shaken hands as knowledge partners, and that particular product is OrthoFX. And their claim is that you can have the patient wear it only at night and still be able to gain the full results of what you expect with a clear aligner. I thought any clinician wishes to have as many arrows in the quiver that he wants to tame the malocclusion or to kill the malocclusion, and clinicians here as well as theoreticians or didactic people here would love to learn and to know more and ask questions and be informed as to what these choices are. To that effect, we have a panel of 4. Let me invite Dr. Efrain Chara, please, to take the seat right there, sir, if you don't mind. Next, I invite Dr. Locke Fan. Dr. Locke, please be seated. I also invite Dr. Carla Mora to take a seat. And last but not the least, a personal friend who has tolerated me as a friend for a small period of 52 years, Dr. Piyush Karia, please. As the panelists are taking seat, please have a seat. I'll quickly introduce Dr. Locke Fan to be the co-founder and chief material scientist for OrthoFax, who pioneered aligner revolution, and he started his journey and developed actually the plastic which is used by Invisalign. Now, he is also responsible, we must understand, he is also responsible for over 263 patents that he has to his credit. Dr. Efrain Chara, he is basically a master in terms of treatment modalities that he tries using in his practice, and he is one of the early adopters of OrthoFX, and he's going to show us the clinical side of it as to how to get things done. I request you all to now listen to the words of my friend, and of course I forgot Dr. Carla Mora, I'm sorry, is the back-end clinical director, and she's in charge of treatment planning, education, training and clinical support. So any question that you have once you listen to them, please feel free to ask. We are already running short of time, so I suggest you can either, if you have questions, go to their booth, or we have social occasion today and you can quiz them one-to-one to get all the answers that you want. With these few words, I hand over to Dr. Piyush Karia for saying a few words. Is there a mic there? Thank you.
Hello. Good afternoon to everybody here, my colleagues and highly professional, literate people from the Orthodontic Society. I am Dr. Karia, a general dentist, Girish classmate and practicing in Los Angeles. I'm so happy to be here to present as a team member for the OrthoFX Team India. Now we all know that evolution in the orthodontics have started in the line of aligners. And aligners themselves have evolutionized. And most of the aligners today, you have to wear for 22 hours. But here is a gentleman, Mr. Loc Fan, who is a polymer chemist and has a craze to innovate new and new things. He worked for Invisalign for 10 years, and after that, he decided to part away and do some research, and has created an hyper-elastic material which is like no other aligner has it. Not only that, this material is approved by US FDA, and the only aligner that can claim to have the results by using nighttime, and that's why we call the aligners as nighttime. When I got attached to this and started talking about the aligners, people asked me what is the difference between this aligner and the rest. So I learned that most of the aligners, till Invisalign, which is the most popular, we have to use it for 22 hours, and this is only for the 12 hours. And the only one which is US FDA approved. So I said, rest of the aligners are apples, and the guy said, what is this one? I said, this is a pineapple. So there is no comparison in two aligners because of the two unique, the merits it has it. I would want Loc Fan to talk about his achievements, since he has so many that I cannot myself describe and tell you. He has developed so many products right from the eyes to every part of the body. So may I present Mr. Loc Fan, a polymer chemist and the genius behind OrthoFX. Thank you.
Thank you, Dr. Karia. Thank you very much. Hi, everyone. My name is Loc Fan. Thank you so much for allowing me to share with you the innovations behind our nighttime aligners. So, a little bit about me. I came from a molecular biology and polymer chemistry background. My background includes the development of cardiovascular device for treating coronary artery application, and the development of paclitaxel drug eluting stents for treating pulmonary applications such as emphysema and things like that. Also worked a lot in cross-linking ATA for the treatment of the dermal filler, breast augmentation and things like that. But in the field of aligner, I actually led the development of materials such as SmartTrack, Zendura FLX, EX30, EX40, Zendura A, and so on. At OrthoFX, I led the invention of our nighttime aligner polymer, our rescue aligner polymer, our bright aligner polymer, and such things. So let's take a look at our nighttime aligner polymer specifically. So if you look at this slide, this is a slide showing the cross-section of a regular aligner. Now it does not matter how many layers the typical aligner material is, whether it be soft, hard, soft, or hard, soft, hard. As long as it is a solid cross-section, it's going to have the same type of shortcoming that I'm going to share with you in later slides. The next part, if you take a look at our normal OrthoFX aligner material, you can see that there is a hollow cross section right here. The hollow torus cross section. The hollow torus cross section is what's going to distinguish the difference between our nighttime aligner and the regular industry aligner. Here is another cross section. You can see the hyper elastic physical property that it's going to be shown the difference. So what is the difference? What is the advantage? So we can talk about the advantage in the 3 F's: fit, force, and finish. So let's talk about fit. The hyperelastic and torus cross section is going to give us the fit capability over the standard industry aligner. For a simple case, it's a lot more, but for a more complicated case, you were talking about plus or minus 4 stages of fit easily, as opposed to the standard industry aligner of plus or minus 1 stage. So that was fit. Let's talk about force. This is a standard loading force for the red curve is a standard industry aligner loading curve, and the blue is our OrthoFX nighttime aligner loading curve, and the green line represents the optimal force range for orthodontic tooth movement. So what I would like to point out here is that for the loading curve of a normal standard industry aligner, we're talking about an exponential rise for stress versus strain. And the rise is a typical rise that you would see for any standard aligner material, a standard aligner material that has a solid cross section. So what you will see is that the rise is, x to the 4th power easily. And what contribute to that is the problem that's associated with having to obey Hooke's law. And according to Hooke's law, stress and strain is always related. And this relationship is exponential, x to the 4th power actually. So now you look at the OrthoFX nighttime aligner, stress and strain. Because of the torus cross section, the stress and strain now is no longer dependent, now it's becoming independent. So what happened is now we have become anti-Hookean, so that force and stress, force associated with stress and strain associated with that, it has been decoupled. So that was the force. Now let's look at elongation to yield. Another word for elongation to yield is range. As you can see, the range in the elastic portion is at least 5 times more than the standard aligner that's in the industry today. It's in the elastic range, if you look at here, it's around 25% versus the 5% that you would normally see in the normal industry aligner. So that was the loading phase. The loading phase is the part where you first insert the aligner onto the dentition. So this is the unloading phase. The unloading phase is very dependent on hysteresis. So again, the red curve is where the unloading phase for the normal standard aligner. So as you can see, this is for a journey of 0.25 millimeter. So for a 0.25 millimeter journey, the unloading curve, as soon as the dentition moves 0.1 millimeter, because of hysteresis and Hooke's law, what happened is that the force dropped down to almost passive. But if you look at the nighttime aligner, what happened is that with the torus cross section, the forces continue to be available for finishing the 0.25 millimeter movement. And what we have here is an anti-Hookean process, and the fact that because of the torus cross section, the air is internalized, so hysteresis is no longer an issue. So that was fit force. And then here is another look at force. This is looking at the unloading curve as opposed, instead of being relative to distance, we're looking at the unloading force relative to time. Time in hours and time in days. So now the red curve is time in day 1, and then the yellow curve is time in day 2, and the gray curve is time in day 4. As you can see on the right plot, on the right plot, as you can see for the standard industry aligner, as soon as the tooth moved, because of Hooke's law, the force dropped down to almost nothing. Now it's becoming almost passive. But if you look at the left plot, the left plot is basically for our Orthovex nighttime aligner, because the fact that it has a torus cross section, is anti-Hookean, the force continue to be available for the movement and be able to finish that movement journey. So that was fit and force. So let's look at this one. This is a bar graph looking at the optimal forces for the 6 types of orthodontic tooth movements. Now, for the next 2 slides, what I'm going to attempt to do is to answer 2 questions. The question number 1 that comes up a lot is that during time when our Orthovex nighttime aligner is not worn, will the dentition relapse to where it was before? That's the first question. The second question is, why is 22-hour wear is something that's required for the standard industry aligner? So this slide talks about the 2 types of tissue remodeling that happens. The frontal resorption tissue remodeling and the undermining tissue remodeling. For frontal tissue remodeling, what required is that application of intermittent optimal forces, and then excessive forces usually will bring on a undermining type of tissue reaction. So looking at these 2 slides, to answer the first question, will our nighttime aligner relapse to where it was when the aligners are not worn between the 9 to 12 hours? The answer is no, it would not relapse, because as you can see the curves that I shared before, the force application is intermittent and is within the optimal force ranges required for moving teeth. So what happens is that it activates a tissue remodeling process called frontal resorption. So with frontal resorption, bone resorption and bone formation happen at the same rate. Therefore, there is bone support. So the dentition will not relapse back to where it was before. But with so the answer to the first question is, will it relapse? It will not relapse because there's bone support. Now, the second question is, why is 22-hour wear required for the standard industry aligner today? The standard industry aligner today requires 22-hour wear because the excessive force that you saw in the loading and unloading phase, bringing on the undermining resorption process, bringing on such tissue reactions such as inflammation and things like that, causing bone formation not to happen fast enough, therefore there's not bone support. So 22-hour wear is required, or else the dentition will go off track, requiring MCC or requiring refinement and things like that. So that was the answer to question number 1 and 2. The next part is finishing. So this is a cut and paste from an article that was published in the Journal of World Federation of Orthodontists in November 2022. If you look at the top bar graph, it shows the mean aligner efficacy of around 45%. But if you look at movement involving the root, it's very poor. It's less than 5%. So that is what is effective. That is what the efficacy is for the current industry aligner function right now. So if you take that and you compare to our OrthoFX nighttime aligner material, as you can see, the OrthoFX nighttime aligner is much more effective in being able to move the dentition along the journey, and the effectiveness numbers in the 80 to 90% easily. And that again is thanks to the torus cross section of the nighttime aligner, being that air is compressible and we don't have to worry about hysteresis, and we don't have to worry about the effect of the Hookean stress and strain relationship. So to sum up that part of it, the two key words are the torus cross-section, because the torus cross-section, the air that is contained within the two shells, is what allowing us to be able to be hyperelastic as opposed to viscoelastic that is normally observed in the standard industry aligner. At OrthoFX, we also have two other types of aligner material that is shown here, the FX Tetra and the Bright. The FX Tetra is just very similar to the current industry aligner today. However, it has much more, it has twice the range, and it still has that compliance forced distribution. The Bright aligner is something that is slightly different. The Bright aligner takes advantage of semi-crystallinity that allow us to be able to wear the aligner and still have the dentition look natural, and it increases the whiteness of the dentition by several shades. What happened is that a lot of the time what people do is they take a standard aligner material and compound in a powder like titanium dioxide or barium sulfate that makes the dentition looks very fake. So if you take a material that is semi-crystalline and translucency, combine that, will give us a very natural looking aligner. Because truly, the standard aligner industry today, although it's called invisible, it really is not invisible. It's very reflective. So with our Bright aligner innovation and the translucency, that will give us true invisibility. So as there is another slide showing one side, on the left side it's just a natural teeth, and then on the right side is where the OrthoFX Bright aligner is being worn. As you can see, it looks very natural, and the effect here is that, you know, when you wear it during the day, it looks brighter, looks like your dentition is brighter. It enhance more compliance. Our other product that we have is called the Rescue Aligner. The Rescue Aligner uses the torus cross-section also, but it's formulated so that it has very, very broad fit range, as much as 4 to 6 to 8 stages. So when a dentition is off track, a treatment is off track because the fact that there is compliance involved or something like that. So instead of having to deal with refinement and waiting for months and weeks to get your aligner, a patient can be wearing our Rescue Aligner for 1 or 2 weeks and still be able to go back to the original treatment plan and continue the treatment. So if you look at this, here's another one on the left, dentition where the patient is off track and the aligner doesn't fit well. After 1 week using the Rescue Aligner, the patient is back on track again using the same treatment plan, the existing aligner that was made for the patient having lost very little time. Here is a bar graph showing the time saving associated with our Rescue Aligner. So this is a retrospective study data looking at the effectiveness or the efficacy of our Rescue Aligner. For case difficulties involving, 3 months, 6 months, or case difficulty involving as much as 12 months treatment time, if the treatment goes off track and the patient is no longer able to fit the existing aligner, we send the patient or the doctor the one Rescue Aligner. The patient wears the Rescue Aligner for 1 week, and most of the time is able to bring that treatment back on track again and use the same aligner that was made or originally in as much as 80% efficacy. Sometimes it doesn't work, and that is because when you discover that the patient is off track. If you discover the patient is off track way too far, then our Rescue Aligner will not work. But if you use a FX on track monitoring system and be able to discover that the treatment is off track with the Rescue Aligner treatment system, we can put the patient back onto the original treatment plan in as much as about 80% easily. So for the next part of our presentation, I'd like to introduce Dr. Chara. If you have any questions about my part of the presentation, if there's no time, please come to our booth at the front, and we can speak in details about your questions and things like that. Thank you so much for listening to me. I really appreciate it. Dr. Chara.
Thank you. I have the clicker here. Thank you. Thank you. Thank you. Okay, good afternoon. It's an honor for me and for OrthoFX to be presenting here in front of such a wonderful group of prestigious orthodontists belonging to the Indian Orthodontic Society. Chara Orthodontics, we practice in the greater Los Angeles area in Southern California. And like 4 years ago, we were providing the service for clear aligners with Invisalign, with ClearCorrect, with other brands, until OrthoFX came to the door, and then I was able to get and to see their products, the aligners that they had, and also the treatment planning by Dr. Mora, who is the head treatment coordinator. So it was very impressive, and I decided, okay, I'm going to jump in and I'm going to give it a try to these aligners. And our journey started 4 years ago. In our practice between 2021 and 2024, the number of patients that were starting with clear aligners doubled because of the COVID, because of the new trend in technology. But the truth is, we were studying 20% of the cases with clear aligners back then, and in 3 years, we're studying now 40% of the cases with clear aligners. This echoes a couple of studies published by the Journal of Clinical Orthodontics, when in the whole United States it's the same trend. It's not that Chara Orthodontics is studying more cases, it's that everywhere we're studying more cases with clear aligners, because we're more knowledgeable, because we have better materials, because we have better treatment planning, and because the patients are asking for that. It's not only, we're just servicing the population what they want. Dr. Terry Salke, he practices in Northern Illinois. He has 3 practices, and he did a study. He compared the last 200 cases finished and he compared between OrthoFX and Invisalign SmartTrack. His findings were, as you can see it here in the where is the? Okay, so we can see with OrthoFX, the total months of treatment, the total number of aligners, the total number of refinements, and the total in-office visits, it was significantly reduced compared to the Invisalign SmartTrack. We can see total months of the mean treatment with OrthoFX, 11 months, against 17 months with Invisalign. Same thing with total aligners, 40 aligners. I want you to keep in mind 40 aligners, because the cases that we're going to share with you, the mean you're going to see is going to be 40 aligners. There are going to be some with 20, there are going to be some with 70 aligners, but the mean is 40 aligners. Total refinements, way less, 0.8 against 1.2 with the Invisalign SmartTrack. Right now, I'm going to share a few cases that we have completed in our practices, not only by Dr. Chara, but also for some of our associates, and other cases completed by other orthodontists across the United States. In all of our cases at Chara Orthodontics, we do use FX OnTrack, which is a remote monitoring system. It's already complimentary for every patient that starts treatment with OrthoFX. So that is very helpful because it tracks the treatment, and we ask the patients to take photos every week or every 2 weeks. And second, by the patients knowing that they need to upload photos every week or 2, it improves their compliance. The first case, this patient we started, she was 14 years old. She came to the office with a moderate crowding in the upper and a severe crowding in the lower. Class 2 bilateral, as you can see. She was only 14 years old. She didn't want braces because the media is helping us. Invisalign, all of these brands are helping us to tell the patients, ask for aligners, do not ask for braces. They don't want, if they're going to high school at that age, 14, 15, they're going to their first, social interaction. They don't want to be wearing braces, they want to be wearing aligners. For every patient, we take a panoramic x-ray, so everything is within normal limits. We do take a lateral ceph, we do some tracings. If you see the E-line by Ricketts between the tip of the nose and mentone, the lips are right in the limit. Maybe 30 years ago, when I went to the residency, we would have decided, oh, this is a case for 4 extractions, so that we can correct the crowding, it's going to help us to correct the class 2, and we're going to bring those lips backwards. But nowadays, we have changed. 30 years have passed, so we have new tools, we have new technology, we have better predictability of our treatments. This patient, only 47 stages. Beautiful, wonderful. She was so disciplined. She wore her aligners as we told her to. And after 47 aligners, we didn't even use class 2 elastics with the patient. And we can see how we solved the upper crowding, the lower crowding, how we have corrected the overbite, overjet. She looks way happier even though the photos were taken with her glasses on. And we can compare before and after. 47 stages, that's like 11 or 12 months. We started feeling very comfortable with these results back then, 4 years ago when we started. So we definitely decided we're not going to go with any other brand, just OrthoFX aligners. All of this is thank you for to LocFan, who's been working with these polymers for 25 years. So he has evolved, and aligners are not the same that they used to be 20, 25 years ago. Now the materials that we have in the market are way, way better than the ones that we have with OrthoFX. Another case, this guy didn't want any orthodontic treatment with braces. Yes, look at the upper arch, a little bit narrow. As you can notice, he had a supernumerary lateral upper left incisor, and the midline, upper midline deviated to the right, and the crossbite. So he wanted to improve his smile, came to us, we decided, yes, you don't want any braces, let's go with aligners, and the panoramic x-ray shows everything is within normal limits. And this is after we did the extraction, I forgot to mention before, we did the extraction of the upper left lateral incisor. So this was like an extraction case. Look at the upper arch, look at the lower arch, 27 stages. Yes, we could have done a little bit more. I agree, we could have been done a little bit more over here on the right-hand side. But for a patient like this is what they're looking for. Sometimes those patients, they're not looking for perfection. They're just looking to feel more comfortable. And we can see the smile of this guy before and after. We don't have a point. So before and after, and how we close the space of the extraction of the upper left lateral incisor. Whether we like it or not, I started my residency 35 years ago. It was Edge Wise. Straight wire was coming. 25 years ago, we started with clear aligners. Whether we like it or not, the band and bracket market is static. It will not see the same growth as clear aligners in the coming decade. There was this study done by marketing and research company. It's called Nova One Advisors. You can check online. It's based here in India and Canada. They said in 9 years, the size of the US market for clear aligners is going to be 11 times what it is right now. Right now it's $5 billion in the United States. 2033, 8.5 years down the road, is going to be over $55 billion, whether we like it or not. Am I saying, oh, all of our patients are going to be treated with aligners? No, I'm not saying that. We still need to use brackets and wires. But this is the trend, and we have to face it. Then nighttime aligners came. 17, 18 months ago, the FDA gave the clear for the nighttime only aligners. And we decided, okay, we're going to give it a try. We're going to see. I had met already, I knew Locke, I knew Dr. Mora, I knew their capabilities, and we started this case with only nighttime. A kid like this came to the office, he didn't want braces. A kid like this, he didn't want to wear aligners for 22 hours a day because he wanted to have a social life. He was playing sports, he was going to the beach surfing. In California, it's very, very, very common. So the panoramic x-ray, the lateral ceph, we decided nighttime aligners. And as I was telling you, this was one of our first patients with nighttime. And these are the results after just 22 aligners. So that's less than 5, 6 months of treatment. Nighttime only. He was living his life during the day and at night when he was resting, and a few hours during the weekends, a few more hours than nighttime during the weekends. These are the results that we found. So look at this, before and after. The photos on the left were right during the winter, even though Southern California, the winter is not that cold. But look at the difference. When the summer started, the kid was super happy with a nice smile, nighttime aligners, and then retention is very important, as we all already know. Another case, pseudo class 3. Patients like this we have seen in our offices. They come, they have been to doctors, that they have been diagnosed, oh, you need surgery. You're a surgical case. But they haven't done, the manipulation of the lower jaw and finding that this is a pseudo class 3. So I decided we're going to go with aligners, not even biturbos. I didn't even add biturbos to open the bite. And we decided, okay, we're going to start with aligners. And this is the result after just 30 stages. I want you to notice, 14 months. 14 months is not 30 stages, it's not 30 weeks. The reason why is because this patient had some family issues. He had to travel outside of the state. So when he came back, he had lost track. So we had to scan again and do a refinement. One refinement, 30 stages, and this guy, he looks like a movie actor. He was so happy. Look at the results. When they had told him this is a surgical case. And we see this every single day with those pseudo class 3s. Misdiagnosed. I enjoy it. 30 aligners. Another case, moderate to severe crowding, upper and lower, class 1. She was in her teens. So back in the days, probably 30 years ago, we would have thought, oh, 4 extractions, easy case, here we go, close spaces. We decided with her aligners, and we wanted to expand the upper arch. Look at the upper arch before, look at the lower arch, look at after. No extractions, 54 aligners, 2 refinements. The reason for this patient, and it happens in our practices, she went to college to the East Coast. So she would come back like every 5, 6 months back to California. So we lost track, but at the end, just 54 aligners did these results nighttime because she didn't want to be wearing aligners during the day. Look at the before, look at after. I'm so glad we didn't do any extractions in a case like this because she was accepted into the University of Connecticut for dental school. So she's going to be a dentist, and she's going to be looking at her smile the rest of her life. And I'm glad that she's not going to say, I had 4 extractions for resolving a case like that. Before and after. Look at the biprotrusion or biprocalia that she had before, and look at the biprotrusion that she had after. Another case, this case was treated by Dr. Neil Warshawski in Chicago. He has a few offices as well in Chicago, and he's also a professor of craniofacial disorders at the University of Chicago. He's very big also into OrthoFX, aligners, and nighttime. Look at this patient. She was very sensitive. This is what Dr. Warshawski shared with us. She was very sensitive. She couldn't handle braces. She couldn't handle other brands of aligners until nighttime came to the market. They're so soft. Patients refer and they tell, I feel like a glove. I personally wore the aligners and I had a treatment to expand a little bit the upper arch. So you see the periodontal, you see the gingival recessions. For us, it makes us think, oh my gosh, are we going to treat a case like that with those gingival recessions? Look at the lower left canine, generalized recession. Because of the soft, gentle forces, he felt very, very confident, and he was looking also with the FX on track, taking photographs every week, and look at the results after just 26 stages. Adult patient, she's over her 50s. I want to see before, look at the upper arch, lower arch, before and after. This is something to enjoy. She had a Bolton discrepancy, I didn't mention. She didn't have she had congenitally missing upper lateral incisors, so the canines were mesialized. And even though with that Bolton discrepancy, look at the results of the occlusion. For an adult patient, over 50, 26 aligners, these people they get very, very, very happy with those results. The thing is, how are they going to pay those treatments in only 8 or 10 months? That's why with OrthoFX in California, and I think here they're going to have it too, they're going to have a financing, third-party financing company. So the patients finance with a third-party financing. The third-party financing pays us as providers, and then the patients pay to that company during 2, 3 years, whatever they want. This case was by Dr. Terry Selke, the one that showed us the other study, the other clinical study. I want to mention this, and I like this case that he shared with us, because look at the retrusion of the upper and lower incisors. Look at the deep overbite. Dr. Sato in Japan, he used to say, the lower crowding is a problem of the vertical. So look at the severe crowding in the lower incisors. I would have doubted to treat a case like this with just clear aligners. But just by vocalizing upper and lowers and correcting the deep overbite, it gives us enough space so we don't have to sacrifice any teeth. Look at the correction of the deep overbite. 36 stages, only 1 refinement, 9 months of treatment. Look at the before and after. And we all know what would have happened if we extract that lower incisor. We still keep the deep overbite, so we're correcting the position of the teeth, but the bite wouldn't have improved as we did. I'm so happy at this meeting to see so many residents coming already to the conferences, enjoying the academics. That's very, very important. Another case by Dr. Selke, an adult patient, generalized spacing, and that's another thing very important for us to diagnose nowadays, that we're changing to the functional orthodontics. Why did she get to this spacing and this anterior open bite? The tongue. Probably she has some breathing disorders at night. So that's something that it was addressed to her. She changed, she started therapy, so it was treated just with aligners. And look at the difference after 20 months. Office visits by Dr. Selke, he says 1 office visit. The reason why he says only 1 is because he doesn't count the initial, he doesn't count the final. So that means during the treatment, he only saw the patient once. And look at the results. But in cases like this, we don't solve the tongue thrusting habit, we don't solve the breathing disorders that she has, most likely at night, this is going to relapse. So that's something that now we're very, very aware, and now we're treating comprehensively. Look at the before and after. Dr. Selke said before she didn't like smiling, now she feels more comfortable with that smile. Nighttime aligners. Another more severe case by Dr. Battle. She also practices in the outskirts of Chicago. A patient like this comes. What created this anterior open bite? Look at the photograph of this guy smiling. We can see the tongue pushing against his teeth. If we don't correct that, everything is we're not gonna get the good results. Extensive dental treatment done to this patient. He decided, or doctor decided to treat him with aligners. And look at 33 stages. just one refinement, and we can see the results. Dr. Battle decided to do retention with fixed retainers, upper and lower, and at night, she commented the patient was wearing the removable retainers from OrthoFX. Again, if we don't correct the tongue thrusting habit, the breathing habit for a patient like this, it's going to relapse immediately. That's something that we now understand. 35 years ago, when I went to residency, we didn't pay much attention to this. Before and after. Yes, he had some whitening done to his teeth, but look at the smile. Another adult patient, 4 extractions were done to her, treated by Dr. Selke. Extensive dental treatment. This is what we used to see, or we see every single day in the United States. Caucasians, 4 extractions, small arches, breathing disorders. Look at the profile, very flat. Patients come to our offices now that they have means and they want to improve, and the good thing, we can offer them a solution. We can offer them, we can improve their lives. 32 stages, just one refinement, nighttime, and look at the change of the shape of the upper arch. Have we expanded? Look at the shape. Have we expanded that lower arch? Look at the shape. Look at the smile. Now she feels more comfortable. She feels more secure of herself. Before and after. Even the overbite was corrected. If you have any questions at the end of the presentation, probably because of the time, we're going to be here at the booth in OrthoFX. It's right at the entrance. And Dr. Lokfam, Dr. Mora is going to be also answering. She is the head treatment coordinator, and that has a lot to do also with the success of the treatments. It's not sending records, it's not sending to someone somewhere moving teeth. She is on top of training all the clinicians in charge of helping us to move teeth. This is a case, the last couple of cases, very quick. This is a case that we started with 4 extractions. I got in touch with Dr. Mora and asked her, Doctor, I have this case. I would really like to treat him with clear aligners because he doesn't want to be treated with braces. That's why he got to this age, like 18, 19 years old, and he didn't want to have orthodontic treatment. So can we please get started with him? She said, let's go ahead. Look at the position of the lower canines. They were inclined, meshly inclined, and they're out of the bone. So that's one of the reasons she told me, I feel comfortable uprighting those canines. This kid was the first set of aligners. It was for 60 aligners, but around aligner number 55, I decided it was losing track, so I decided to scan again and send for more, for a refinement. And right now he's on aligner number 74, like 2 weeks ago, out of 80. Can I continue 1 minute? Look at the before and during the treatment. He's on aligner number 74 out of 80. That's a year and a half. That's only a year and a half into treatment. Yes, we still need to work on the canines. They're still out and I hope with the last 6 aligners, we're going to bring those roots inside of the bone. Last case that I wanted to show you, another nighttime aligners. College student doesn't want braces because now that's the trend. He doesn't want to be wearing aligners during the day because they're snacking, they're eating with their friends. They don't want to be that problem. They don't want to lose those aligners here and there. So we decided, okay, let's treat you with nighttime aligners. Periodontally, we tried the best. Sometimes these kids are very stubborn. And these were the results after just 40 aligners. 40 aligners is 10 months of treatment. Nighttime, only 1 refinement. And we did that in 14 months. Why 14 months? Because kids going to college, they lose track. Look at the before Look at the after. Are we expanding those arches? You judge. Look at the lower arch. Look how we corrected the crowding. All of these, again, thank you to LogFam, who has developed this new wonderful, soft, hyperelastic material that allows us to put pressure, intermittent forces. And for us, it was kind of, but I was taught that it had to be for 24 hours a day, light forces to move teeth. What's going on? So probably it's a paradigm shift. These are the results. Studies are in progress right now. There are some already papers published. We can discuss that at the booth. But there is something happening, and these are the results. I also sometimes I compare, it's like when we do exercise at the gym. Even though we exercise only for 30, 40 minutes, but the memory is there. And then the muscle produces a result after a few hours or days. If you have any questions, here's my personal email or phone number. Feel free to contact any of us at OrthoFX at the booth in the back. Thank you so much, and enjoy the rest of the meeting.
Hello.
Once more, I have to make some announcement and a solemn duty to inform you, all my colleagues, that OrthoFX has come to India only because of few people who have made it possible. And one of the person who started with me is Dr. Sushma Patwardhan, my classmate, and then a friend of mine and Girish, his name is Kirit, and then the rest is all shouldered by nobody else but Girish Kanathinkar. I think we owe him a big applause. He is the only person who has run 12 months to make it happen. And there is one thing I want every one of you to know. Dr. Jayesh Nihalkar, who came to US, and he had one request only, that all the orthodontists should be treated equally and there cannot be tier system. If there is a tier system, I'm not going to work on it. So it was surprising to all of us that he is already a golden member and he gets, but his concern was a new orthodontist who practices beside me, how is he going to compete with me? So I have not seen a person and a president of this caliber and so honesty. I owe him a great respect and we all owe him a respect. I think if you get chance, please thank him. There is nothing beyond what his thoughts are for the whole community. Now one more addition to this. The gentleman I introduced, that scientist, Pham Lok, he is the genius guy and he has 256 patents only on aligners, oral, and 500 and odd figures total patents international on the other parts of the body, what he has created. So that genius he has worked and his march is on. He said, Piyush, march is on. I don't know what is he coming out. I said, what have you thought? He said, I might put the perfumes so that it smells like lavender and you can sleep well. You can have it from him. Now, Dr. Chara, he's a wonderful practitioner. He also has a passion of sailing and yes. Now we have 2 minutes more if I take aapse ijazat chahta hu. The one who has worked both in Invisalign and OrthoFX, she can tell you if you have any questions after she says what she saw. So I would take 2 minutes from her.
Piyush, thank you. Thank you. Are there any questions? Or would you like to take the questions in person by going to the booth and asking them, or do it because we are already running late? So if you have any questions, my sincere appeal to you would be, you go to the OrthoFX booth and or during the banquet, if you feel like with something tall and amber, you can ask them questions. Thank you. I just want to tell you that I have no commercial interest in the product. The product was offered to me, I don't know, I could not hear what Piyush was saying. It was offered to me in person, saying that we'll be the partners. I said, no, I don't want to do that. I want to give it to iOS. If iOS can make some money out of it, great. So apparently, if the partnership of OrthoFX and iOS continues, OrthoFX is going to pay approximately 1 crore rupees to iOS every year. If we can use that money for whatever purposes we want, I think that will be something great. And I know that I have several friends. If I fall on a bad day, I can go to any person's house and knock on the door and say, Om Bhavati Bhikshandi, give me a free meal, right? So this is what I think we should do. This is what I've done. Thank you so much. If there are any questions at all over here, please tell me, so I'll direct them. Otherwise, are there any questions? Any yeses? No, I don't see a question. So thank you very much, the panelists.
He is telling 100%. I offered him that we make partnership. He says no. Here is the guy who has sacrificed everything for iOS.
Happy to do that. Not a problem. Thank you so much.
So I request Dr. Manjunath sir to give the certificate to Girish Karandikar sir for the moderating this session. Sir? I don't know, they mentioned me about your certificate.
I don't need a certificate for helping my own association. Well, if you don't mind, put your hands together for the efforts of these people to have come over and explain to us what the technology can do. Thank you. Thank you so much. Thanks.
Oh, next is an impact talk by Dr. Swarup Savanur sir. I request Dr. Nariman to come and introduce Dr. Swarup Savanur sir.
Hi. Dr. Swarup Savanur is one of our celebrity mental conditioning coaches of India. A brief work profile of his, but before that I'll just give you the different qualifications he has. He's a diploma in EEG and brain conditioning from Switzerland. He's a master's in psychology. He's got an MDS in ortho from KLE Dental Belgaum. He's a certificate of science of young athletic development from University of Florida, and he's in exclusive mental conditioning and mental training for elite athletes since 2001. He's been associated with the Punjab Kings IPL team since 2001, 21 and 22, I beg your pardon. BCCI's National Cricket Academy with 18 plus high performance camps which he's performed for India A, emerging and under 23, under 19 at NCA. He's been associated with the Indian football national team for FIFA Under 17 World Cup of 2017. He's a director of peak performance for Vidarbha Women's Cricket 2023 and the lead consultant for the Army Sports Institute, which is India's premier Olympic institute to maximize potential of India's boxers, wrestlers, archery, weightlifters, diving and athletics. He is training Olympic, Asian and Commonwealth athletes, including many of India's top 10 for multiple Olympic disciplines. He has helped 11 elite athletes win medals for the country at Commonwealth and Asian Games, including one athlete who has become the world #1 in badminton, India's first ever. He's with the Vidarbha Ranji cricket team from 2013 to 16, along with the under 19, under 23 men's teams, with elite senior and teen athletes for tennis, golf, badminton and other sports. He's got 15 plus tours for Ranji, under 23, under 19, with both men's and women's cricket teams. He's the founder of My Mental Coach, India's premier mental training company for athletes, students and professionals. And last but not the least, you can make him sing a damn good song. I present to you Dr. Savanur.
Hello. Hello. Namaste and good afternoon, everyone. Really such a pleasure to be here after so many years. First of all, I would like to thank Dr. Anup, a close friend of mine, my batchmate in my orthodontic days, for inviting me here for such a good concept, right? Small 10 to 15 minute talks. We hear TED Talks so much. I think so there is a merit in having more such talks so that people can learn not just orthodontics, but something even more than that. Great initiative. But today, of course, I have come here not as an orthodontist. I have come here as a mental conditioning and a peak performance coach. Although I was listening to the talk that was happening before, and I thought suddenly that there's something in common actually. They were talking about aligning the teeth, I'm talking about aligning the mind, isn't it? So probably there is some similarity. So today I feel that we are in the era of peak performance. Actually, if you think about it, because sometimes we actually don't reflect on what's happening to our life today. For the first time in the history of a civilization, a majority of people today have already got the Maslow's needs already met. The basic security, financial wealth, housing, food, all these are met. And because of technology, we have now got a smartphone, irrespective of whether you are a poor person or a rich person. Learning is something that has become, the world is flat in terms of learning, isn't it? And that's a huge change. You no longer have to go to a university, pay, you can do it at in the palm of your hand. Communication is amazing. But at the same time, think about this. As these things are happening, wouldn't you agree that the more we are having communicative devices, the more we are getting isolated as a species? The more we have got artificial intelligence coming to us, the more our natural intelligence is getting threatened. And in a way I feel that it's a very fascinating time in our life. And therefore, rather than putting a statement, what I would like to do is to put an argument in front of you, for you to introspect, and let's see what you think about this in your own mental space. And the argument that I want to put across is, what do we really mean by peak performance? Because we can clearly argue that all the people over here are peak performers. There is no doubt. Everybody has done so much in their life, struggled, fought, succeeded, and gone to the next level of whatever they are doing in their life. Me being in the field of sports, I see this every day, day in, day out. Fascinating talent at the age of 17 and 18 years, whom everybody can bet on, can surely reach the international stage. But so many of these athletes, probably by the age of 23 and 24, have not even gone to the national level, forget the international level. So what is it that would be stopping them, isn't it? Because talent is surely not the reason, skill is not the reason, resources are not the reason, opportunity is not the reason. So what is the reason? What is it that prevents them and probably all of us to remain to a certain limit, and we go there fast? Sachin Tendulkar went fast, directly went into the Indian team at the age of 16 years, but others couldn't. Others had to go through those barriers. But many of them, although more talented than Sachin, were at the state level, were at the national level, or couldn't even cross through Ranji. So what is it that's stopping them is the question. Ask yourself this question today. Is something in your life stopping you from achieving what you feel is your greatest success quotient? Not just in your profession probably, but also in your life. And that's the question with which we are going to talk about the 10 mantras of achieving peak performance. Now, why mantra? Why not principles? I think so that's a very important question to ask. What is a mantra, isn't it? And mantra is something that is so ingrained in our philosophy, isn't it, as a India, as a country. Om Bhurbhuvasvat Tat Savitur Varenyam. What does it really mean? They can be just Sanskrit words. But no, there is a power. There is a lot of emotion. There is a lot of essence that is built into those words that give us a different kind of energy, a different kind of meaning, a different kind of approach, and a different kind of a thought process with which to look alive. And therefore, I feel today we don't need principles in our life. We need mantras in our life. We need to know what are the things that we can remind ourselves of every day, just like we do a mantra, so that we can keep going towards that peak performance that we are trying to say. And therefore, I'm going to start with the 10th mantra in mind. And every mantra, 10th word, 10 words. And the first is, consistent mindset with a clear process leads to holistic success. Let's split it up quickly. Consistent mindset, but with a clear process. Many a times, we look at mindset not from a consistent, but many a days, I am not able to do that. I do it once a week, I do it twice a week, and I don't realize how I'm taking it down, how I'm taking my potential down. But why does that happen? Because it's very difficult to control our mind. Because mind, right now, the audience that is there in front of me, I can bet 70% of the people over here are having their thoughts with them, coming towards me, then going back, then shifting ahead, then visualizing something, again coming towards me. See the way your mind shifts just even in this 20 seconds that we are talking to each other. And we aren't even aware of it, isn't it? And that's the fascinating aspect of mind. It's so difficult to make it consistent. And therefore, unless we have a process by which we are able to control our mind, we will not be able to control it. Just as a player needs to have that forehand the way he needs to, a Djokovic and a Federer's forehand is going to be different. But both will have to hit down to up. The principles of forehand will not change. The individual may make that small change, isn't it? So a consistent mindset with a clear process is the key. But to make a consistent mindset, I need to start somewhere. But I need to start on that daily basis, isn't it? So the 9th mantra that I would look to propose is focus on daily success. But how do I focus on daily success? What does daily success mean? Ask yourself this question. Does daily success mean that, okay, for the next 5 days in that week, I'm going to sleep at 10:30 or 11 because I want to get fresh and get up early the next day to go about my fitness goals? But when you have got your mobile in your pocket, sometimes you're not going to be able to do that, isn't it? And it is these simple practical things that make you go away from your daily goals. And that is the reason you can't be consistent. So how do we focus on our consistent goals? If you decide today, okay, I want to make that change happen in my life. I want to really be successful on a daily basis. The question is, how can I do that? And the step number 1, friends, I feel, is always self-awareness. Every day we look in the mirror, right? We look at ourselves, how we are looking. We comb our hair. We always give ourselves a time to scan ourselves. Don't do that? We scan ourselves, right? We scan ourselves on a physical level. But why can't we scan ourselves on a mental level? Why can't we scan ourselves on an emotional level? Why can't we look at ourselves and tell us, what are the thoughts and emotions today that are probably troubling me? It's very difficult to do that. And therefore, unless we have a process to start the self-awareness journey, it's going to be very difficult for you to improve. And when you look at self-awareness as a thought, you will realize this 7th mantra is actually the transition between thinking about it and doing something about it. I'm sure so many of you must have thought about doing something. Let us say many of you must have thought, I want to invest money in the stock market. But you know what? There is a risk. There is a reward and there is a risk. How do I really make up my mind to go towards that fear of losing money is the question. And imagine this one thing, if you're stopping from doing, in today's India's greatest growth story, when else are you going to invest in the stock market? Right? But at the same time, ask yourself this question, which are those thoughts that would be troubling me? What is that fear? And believe me, the fear always starts with that one word that we say, right? Failure. We don't want to fail. The biggest difference that I see between sports and the corporate world is this. In sports, athletes are used to failure. Athletes are used to failure. In our normal life, we don't actually fail much. We don't want to also fail much. So it's very easy to say failures are the pillars of success, but it's very difficult to actually be a failure in life. So how do you look at failure, how do you go towards the fear is what is the critical component for you to actually manage that fear. But once you decide to conquer fear, there are other factors that come into play. And the biggest factor that I feel that stops people is by comparing ourselves with what our other people are doing. Right? And the mantra which I feel is very powerful is do not compare yourself with others. Because every person truly has a different journey. Every person truly has a different meaning to their life they are leading. And it cannot be connected to what the other person is doing. So this is something, especially when it comes to material wealth, is what we see this impacting us and therefore impacting our decisions. And beyond, when you go towards it, you go to the fifth mantra. And okay, if you decide to do something about it, discipline is the required for achievement. But what kind of discipline? There is a book by Robin Sharma, you know. He said that it's very easy to mind the children, but who is going to mind yourself? Adults are nothing but deteriorated children. Right? Who is going to mind ourselves? We have to do that. So today's critical skill, I feel, that we need to develop as adults is self-discipline. What can I do to discipline myself on a daily basis so that I can do what I need to do every day to go towards the goal that I want to achieve? But for doing that, is it comfortable? No, it's very uncomfortable, isn't it? It's very uncomfortable to do that every day because your mind is going to push you away from exactly what you want to do. That is why in Gita it is written, right? Your mind can be your best friend and your worst enemy. It's written 15,000 years ago. And therefore, if you want to push your mind, you need to understand that you need to be uncomfortable. You need to face those uncomfortable situations. On the third part is your real wealth. And what do we mean by wealth? Today we are in a generation where wealth is there. But I feel wealth is asking the right questions to ourselves about what do you want to do in your life. It is your search for your own truth that you want to achieve in your life. Because that truth is what you want to really do in your life. And when you do that, you go towards your own personality. You become yourself. Again in the Gita it is written, you are an extension of your personality, nothing beyond that. And your search for truth is an extension of your personality. So as long as you connect to your personality, you will always find the answers to your challenges that you are going to face. And finally, it is about living. Today, the concept of living has changed. I always look at living from a very amazing factor. We want happiness, right? But happiness has got different connotations. Happiness can be happiness because of having money, buying a bigger car, buying a bigger, vehicle. But from beyond happiness is pleasure. Today we are a pleasure-seeking society. We want to go somewhere else. We want to go click selfies. We want to go binge, watch so many things. Why? What is the reason? It is for pleasure. It is for getting that dopamine kick that every day we want to elicit in our minds. But I feel, friends, the real thing, the real key is bliss. In yoga, it is called as samadhi. Dharana, dhyan and samadhi. Where you are at peace with yourself. There is so much of a greater joy with what you are doing. And that, in a way, I feel, is peak performance. But the beauty of this peak performance is that each and every of these steps is required for peak performance. Because it is like playing cards. Even if one card goes, the whole thing collapses. And that is the beauty of peak performance. And that is why it is difficult. Because you cannot have something unless you bind something with each other. And what is that binding force? That binding force is inspiration. You need to be inspired. You need that inspiration, that drive is going to push you towards these 10 mantras, to push you to be uncomfortable, to push you to seek the truth, to push you to do the things that you really want to do. For me, it was my inspiration. What was my inspiration? 20 years back when that article came in the Times of India, if we can't win at sports, we can't win wars. That article has changed my life. A second inspiration happened for me when that poor boy knocked on the door and I kicked him away. That led me to write a story, and today I'm also a filmmaker, writer and director. And I feel that these inspirational moments are something that you need to absolutely take yourself and grab those inspirational moments. And when you do that, you will start looking at these 10 mantras in a very different way. Finally, I feel that peak performance is within your reach. With the right intent and drive, and with the right process, you can achieve beyond what you can imagine. And I hope you start that journey, because peak performance is never a destination, but it is only a process that you'll have to go, and it's the path that you take that's going to lead you to holistic success. Thank you very much. I'm sorry if I got 2 minutes late.
I request Dr. Vishwanath Kedilaya sir to come and give the certificate to Dr. Savanur sir. So we'll be starting with few more interesting lectures. The next speaker for today is Dr. Narayan Gandekar sir. I request Dr. Manjunath sir and Vishwanath Kedilaya sir to please come over the stage and chair this session.
A very good afternoon, everybody. I think the organizers have very well planned for Dr. Narayan Gandekar's talk after lunch to draw your attention here. I would like to thank the Scientific Seat Committee for giving us this chance to moderate my alumni. He's a proud alumni from SDM and a student of Dr. V.P. Jayade. Unfortunately, due to change of schedule, he has to leave now, but he has blessed Dr. Narayan and went. And he is also trained from with Dr. Eric Liu in Taiwan. His CV is quite big, but I think all of you know about him much. I don't want to take much of your time. In brief, he is right now he is a postgraduate supervisor and a course director of the orthodontic course in University of Sydney. And he has numerous contributions in the international literature. All of you know about it. He is an Australian board certified, holds a membership of ADA, branch of academic membership of Australian Society of Orthodontics. He is an associate editor of Seminar in Orthodontics. He has done numerous workshops. He is a speaker at American Association of Orthodontics. More than everything, I had the experience of going to his place in Singapore where he was working as from the iOS side, sent me there. I saw him. He was very open in showing me what and all work he does there. I have seen his struggle, and right from his postgraduate days, he is a very humble and very passionate about sharing his knowledge. So I would like to present to you Dr. Narayan Gandekar. He is going to show us the way he does, the way he shares his knowledge, which he has achieved over the years of time with a lot of hard work. Over to you, Dr. Narayan.
All right. Thank you so much, Manjunath. Without much ado, I would like to thank the organizing committee for getting me here. What a fantastic show. And I've been nothing but enjoying it all the way more and more since the day one. We had a pre-conference workshop. And I was talking about surgery first while I was trying to rebut my case against TADS a couple of days back. And here I am on the other side of the aisle talking for TADS. So probably those that attended the pre-conference workshop must be in two minds. What this crazy guy is all about? Look, I'm here for orthodontics, and let's try and make sense about what TADS got to do in terms of the paradigm that's already there, how far the TADS have come, and what they need to be doing in terms of expanding that envelope. So I'm going to talk about my experience about treating some of the cases that I have come across in the past 16 or 18 years of my practice, and I'll be talking about some things that you might want to take home along with this presentation. Like I said, thanks for the Indian Orthodontic Society. Thanks for Bangalore Orthodontic Society for putting up this massive show. I'm really, really thoroughly enjoying this so far, and I hope all of you are as well. So a little bit about myself. I studied from SDM College of Dental Sciences, and then I took a position of assistant professor there for a couple of years before I moved on to Taiwan from 2009 to 2011. This is where I learned a great deal of craniofacial orthodontics, along with some aspects of temporary anchorage devices that I use nowadays. And I'm fortunate that Eric is here amongst us. Hopefully he'll turn around and say that not a bad presentation after all. Before I moved on to University of Sydney, I was at this place called Singapore. I was there as a resident specialist for the Cleft and Craniofacial Center at KK Women's and Children's Hospital. So I had an incredible ride for about 8 years there in Singapore, where I could put forward my experience as well as learn from this highly integrity-based surgeons that I still revere, and kind of take home message with so many memories, along with a kind of experience that I still emulate or try to emulate in all of my especially craniofacial syndrome cases. Now, for the past 6 or 7 years, I'm in this beautiful city called Sydney, along with my family, with one wife and 3 children, not the other way around. This is my team now, this is my people, this is my go-to guys, and headed by this nice young and handsome gentleman called Professor Ali Darin. I think he's reversing in his age, if I could say so. And we have some very beautiful, fantastic postgrads there as well. And I call myself as a privileged postgrad supervisor in one of the finest dental schools that I've come across in my life. So what's the fuss about? Why I need to talk about TADS? What is there for you to take home from my experience? I'm going to just simply divide them into 3 categories and try and see whether I can make some sense in terms of transverse, vertical, and sagittal corrections, the way I approach it. Now, as I said, attention to details is very important. This is one of the cases treated by Dr. Basavareddy, one of my fine colleague from SDM Dental College and Sciences. What we can come across from these cases is you have to pay attention from the very go. Once the patient comes to your clinic, try and make sure that you have that eyes going around without making the patient feel creepy about it. Try and get a sense about how the patient is so that you can have some dynamic assessment as the patient is going along talking about their problems of orthodontic treatments, so that you put forward that patient into rule of fifths and rule of thirds. And now this is something not new. This is Gnathic profile field, or rule of third or rule of fifth was given by A.M. Schwartz long time back, maybe in the 1930s. I'm just trying to bring the memories back, or trying to resurrect the memories of those that have forgotten, the giants of orthodontics. They have done it all. I'm not saying anything new about it. I just want to reminisce some of these and try and bring into my practice so that you can make sense about what I'm going to show in this 40-45 minutes. So we wrote a chapter in this fantastic book called Expanding the Limits of Orthodontic Treatments by these South American chaps. You should read this book, one of a kind. And we shared this privilege, actually. I shared the privilege with Nick. We wrote a textbook titled Temporary Anchorage Devices, Evolution and Overview of TAD Applications. Probably if you're interested in historical aspects of it, probably this is the chapter to go to. Otherwise, if you're not interested in this is the gist of it, actually. If you don't want to read the textbook, entire topic, basically, I'm trying to talk about is the TADS evolution, and I'm going to talk about some of the TADS that I'm going to use. Basically, the Lin and Leo Lomas mini anchorage system that came into existence in 2003, and since then, maybe in 2008 or 9, I started using this appliance system. Fantastic appliance to go with. I'll show some of the cases that I try and use these appliances in my practice as well. So, first things first, let's try and divide this into vertical corrections. Open bite. Now, this is a topic which is very close to my heart because it is multifactorial. It's very hard to predict where the habits come from. So if at all you're looking for etiological factors, open bite should be your case. And some of the common culprits are habits, neuromuscular deficiencies, trauma, and some sort of diseases which are affected the maxillomandibular complex in general. So I usually use this classification. Again, this is from the 70s. So the classification simply lets you know about what is the open bite, and this essentially gives you a treatment plan in per se, because it tells you about simple compounds and infantile open bite, and it also tells you about probably there is a little bit of a clinical features that are involved in it, so that you can address them as accordingly. Now, skeletal open bite, usually also called as long face syndrome, some of the classic features that come along with the excessive anterior face height and so on and so forth. So what's my goal? How do I do it? Is I usually divide them into camouflage line of treatment, extraction or non-extraction or surgical. Now, surgery is very close to my heart. Any open bite that comes along with the skeletal tendencies, I usually offer them a surgical line of treatment just to save myself, because there are lot many cases that require surgery in open bite cases. If they deny it, then comes the patient such as this. He says that I don't want any surgeries, but I want to get corrected my open bite cases. Now, in open bite cases, one thing you should realize is they almost all the time, they have root resorptions in the upper anteriors. Only or solely because of the fact that there is some sort of a dysfunctional atrophy that sets in, non-functionality of the upper anteriors. So make sure that you end up taking at least a periapical radiograph of these upper anterior teeth, and don't be too surprised if you have slight bit of a root blunting, or even the roots are chopped into half, because that's a very classic feature of an open bite, and it usually or solely comes from the fact that non-functionality, they can't use these front teeth, so they end up becoming a disuse atrophy, and ultimately the roots end up having a resorption. So if that's the case, how I use my TATs in those cases is I usually do a very conservative process, in the sense I usually extract the upper force and try and end up the case finishing in class 2 molar relationship. Now, if you look at it, if you have a TAD in this case, you can't be putting that TAD in a very high position. Why? Simply because of the momentum that creates has to have some sort of a maxillary occlusal plane, rotation of the occlusal plane in the clockwise direction. And there are some of the other things that you need to know about is, if you are placing your TADs, try to place the TADs as low as possible in an open bite case. Otherwise, the open bite will not resolve, but in fact, it will contribute to the open bite, and you might end up having an unresolved open bite for a long period of time. So this is a sequence of treatment photographs that has happened. So once you close down the space, I usually all the time put settling elastics, and some amount of retention needs to be taken into account. Right? So we published this paper way back in 2013, and if you want to read more about it, please pursue this. We have written a little bit more about the biomechanics part of it and how it goes over a period of time. So we have a follow-up of about 3 years in retention for this case, and this is how it looks like in comparison of pre-treatment prediction VTO and actual post-treatment outcome. So if you look at the vertical correction, it pretty much stabilizes there over a period of time. If you know the etiological factors about open bite, or if you know how to treat a case in terms of open bite, please follow the classification so that you can segregate what amount of malocclusion is contributed by skeletal and dental, and then further go on correcting it. Now, I want to bring notice to you this case. Retreatment case, aligners gone wrong. Now, everybody gets excited when they see an open bite case. Let me treat with aligners. That's the go-to mantra. I don't want a deep bite case because they're going to make it worse. But if it is an open bite, I'm going to treat it as good as a piece of cake, right? So this case been in treatment for 6 long years, and patient was unhappy. Ministerial referral happened and went into a lawsuit with the practice, and they had to intervene and transfer it to my faculty practice at the University of Sydney so that we can mitigate this problem and close the report. That's how it goes in Australia if you end up having a case which is mutilated by any sort of treatment, right? So if you put a face to it, it looks something like that. Now, clearly that's a surgical case. Now, I'm wondering what happened to the practicing orthodontists who wanted to treat it with aligners. I'm not sure about that part. So first things first, I told them that this is not a case of aligners. We need to get rid of all those attachments there. So that's the picture of the patient once the aligners came out. And then I had to tell her that this is a surgical case, I should not be treating you in any means. But she had already lost her faith in orthodontic treatment. She said, I'm not going to get into a more invasive procedure. So what I told was, there is something that is very less invasive than the surgical procedure itself, but nonetheless it requires some amount of invasion in terms of the temporary anchorage devices itself. So what happened was, I happened to put 4 TADs in the buccal segments so that we intrude the posteriors bilaterally, not just the maxillary occlusal plane, but also the mandibular, so that the kind of the divergency that has been set with the open bite comes into the normodivergency. And eventually, once you do that, if you look at the second row, top second row, and the middle row, the open bite seems to be correcting by itself just by using a posterior intrusion. But what happens is anteroposterior starts showing up. You will end up having a sagittal discrepancy that needs invariably extraction. So nonetheless, we had to extract in this case and also put a mouse trap in order to maintain the corrections that had been brought about by the buccal occlusion, buccal TADs. So in sequence, this looks something like that. So you have to have both bilateral TADs as well as a mouse trap which will hold on to that correction. And I tend to use some amount of a blue glue in order to maintain that molar corrections that has been brought about by molar intrusions. Right? As we go along, now I extracted upper premolars, and I'm trying to retract them as much as possible in order to get rid of the AP corrections. Now open bite, vertical corrections has been taken care by the TADs, but the AP correction remains. That's the reason why I'm extracting in this upper arch. So eventually the patient looks somewhat comfortable, and I'll ask her to wear some elastics in order to get rid of that midline discrepancies, and she eventually gets a little bit of semblance of how a smile looks like without an open bite. Otherwise, they end up pretty looking bad in terms of if they have an open bite, their smile line becomes more like a incompetent smile line, if you may. This is how she looks like after 2 years of treatment. And then this is how she looks like at the end of the treatment. Now, if you pay attention to the second molars, they are mulberry molars, but they are not related to any diseases. It's just the ethnicity that comes along with that aberrations in terms of molar relation. That's why I couldn't get a proper second molar relationship there, because the morphology of the second molar itself was limiting to get a proper occlusion. Nonetheless, I feel that this was not a bad place from where the aligners started, and then it went to ministerial complaints, and then patient gets some sort of sense of how teeth look like in terms of normal occlusion. Now this is how the pre and post treatment comparison, and I usually end up placing vacuum form retainers in all the malocclusions that have got open bite cases. That helps to maintain the posterior occlusion in the occlusion itself rather than starting opening up. So you must be wondering what happened to the cephalograph. So if you can see that there is a good amount of clockwise, anti-clockwise rotation of the mandible. This is the pre-treatment, and this is the patient's 2 years in retention. So I hope that whoever has treated or whoever is treating patients with aligners and open bite, I might want to bring to your notice that not all cases which are with open bite are not suitable for aligner cases. Now I usually use, people must be wondering that what is the bracket position. I don't change my bracket position at all. I'm a thoroughly MBT guy which follows the dictum of MBT that has been given by a very long time by McLaughlin, Bennett and Trevisi. My appliance is very simple, and I keep my appliance and the bracket position along Lawrence Andrews plane and the long axis of the clinical crown. And these are the brackets that I usually use, which usually gives me a predictable result and some sort of a result that I can repeat one case after another, because they have got that inbuilt tip and torque, and I think 3M has done a fantastic job in terms of how these Victory series have come into existence. Now the some tips, open bite, strongly associated etiology, multifactorial, so you can't just rely on finishing a case and not have a retention plan. I tend to use a vacuum form retainer so that I can maintain the posterior occlusion intrusion that has been brought about. And some sort of a treatment plan needs to be taken into action. Based on diagnosis, choose your poison. If it's an aligner, you better have your socks pulled up properly, otherwise you're going to end up in a big soup that you can't even rescue yourself from that point of time. Right, let's change our gears and get into the distalization part of it. My take on distalization is it's a very hard part of treating. If you don't know how to do distalization, let that be the last choice of treatment in terms of gaining space, because this is one form of gaining space, to be very precise and practical. So this is my go-to indications and contraindications. I always think about this slide when I'm talking about distalization. I never ever go past this slide if I'm using distalization as method of gaining space. Now remember, it's just a modality. There are many ways of treating a case, and distalization is one among them, right? So why there is an advantage? It avoids premolar extraction, especially in those cases which are straight profile, and in those cases you must avoid extractions in any given point. Disadvantage is that there are plenty of them. Extraction of third molar is a must. Possible impaction of third molar, if you don't know how to distalize, you cannot jam and jack it up. Or no more to hyperdivergent facial profile, because distalization, you picked up the wrong armamentarium, wrong methodology to treat a case, and it became a vertically challenged case because you simply distalized and led to a jacking effect, which led to normodivergency to hyperdivergency. So some of my cases, I'm going to put up these cases into upper molar distalization, bilateral molar distalization, class 2 division 1. Some of stubborn cases such as class 2 division, subdivision, I find it very hard to treat, so I use distalization in those cases. And some class 3 cases where I do both en masse distalization and open bite plus distalization. So let's quickly jump into the case. Now Peter is a young boy, adolescent. If you notice that the upper right quadrant is in crossbite, and also he has got an impacted canine. Now this is a perfect case for distalization, as I mentioned in the previous slide. Right, so what's going to happen? My choice is to use Lomas mini screws, and I tend to do a distalization using a bilateral attachment. Now in this case, the vector needs to be taken into account, because you have to correct the crossbite as well. Now, how do you go about it? You don't have to touch the canine. The big boy will come down, slide through it, because you're creating space at distal to the canine. The canine is in the eruption stage because Peter is quite young, so you don't have to touch the canine to do anything further about it. Let it come, let it fall down by itself, and as the time goes across, you'll realize that there's barely anything can be done to that canine, because it will come down by itself, because the patient is in that age group where canine can slide down on its own account. So this is how the sequence of treatment happens. Once the distalization is completed, you can use it as a stabilization itself. Unlike the conventional where it typically takes the anchor of the premolar, then we have to sever the premolar bands, and then we have to make sure that how we are going to utilize this space that has been created distal to premolar. So in these cases, you don't have to worry that part of it, because once you distalize it, the same implant can act, and you can distalize them as much as you want, and then you can utilize them to create the space, align the occlusion, malocclusion that you intend to correct. So this is how he's going to do it when he has school holidays. So I think he came back after school holidays treatment where he has his tutu built up as well. So I think it's a fair bit of decent result if you look at 1 year post-treatment, which is more solid, more predictable emergency, because it might look good in occlusion, but when you put a face to it, you might end up having a hyperdivergency. So be careful about that part. Now, in the next case presentation, I'm talking about upper bilateral molar distalization. Now, in this case, she is a late mix use this distalization technique quite often. Why? Because I'm quite used to the, again, in this case, you don't have to bracket any upper or lower front teeth. You just keep distalizing it, and over appearance with the orthodontic arch wire itself. And if you require further amount of distalization, I usually use a blue glue that allows some sort of a disocclusion, doesn't allow the interdigitation of the posteriors, because interdigitation of posteriors may make the distalization process slow down. So if you're keen on it, the blue glue comes in real handy. So this is how it continues. and the TADS comes out, some final, I always keep an eye on the face, mid-treatment phase, because I don't want to further distalize it to such an extent that patient gets a distant facial profile. And final finishing, some maintenance of distalization by class 2 elastics. This is how she looks like right before debanding. This is the sequencing that I usually do. I have a fantastic, incredible technicians that do the job for me. My job is to just place those stats and make sure that it is biomechanically sound. That's how much is my input. This is how she looks like from beginning to end. So non-extraction, distalization, again, pick your poison. It's not a must that distalization is a must in every case. If you played your cards right, probably you will win a big lottery out of it. Otherwise, be prepared that it's a very long, lengthy, deliberate process. Distalization should not be attempted if you don't know the untoward effects of those. This is how she looks like. Sorry, this is how she looks like post-treatment. This is the comparison of pre and post. Now I'm scooting because I've got another 100 slides to go. So distalization and expansion. So in this case, what we are talking about is a case that calls for distalization and also expansion, because as you see the face, it's pretty much dished in. There is barely any room for extraction. Should you extract it, you might end up further retracting the face itself. So in those cases, what I do is I usually band up the first molars, put a kind of I call it as an octopus that has got its multiple hands going around, multiple legs going around, so that we can have both expansion and distalization. So I start with expansion, and then distalization will continue along with my arch-wire sequencing. I start the arch-wire sequencing as low as 012 NiTi. This is my go-to wires. 3M has got a good, fantastic wires that give you enough super elasticity to work around with. Again, if you're tending to distalize, put some blue glue at the back so that you will not interfere, the intermaxillary occlusion does not interfere your distalization process. And also make sure that you're taking photographs frequently, because distalization usually tends to make the lower anterior face height increased, or you'll end up having a vertical problem. So this is how I change my expander distalizer to just a distalizer, where I'm trying to distalize, because on the left-hand side, it still needs some amount of distalization. So it's a unilateral distalizations come the expander, the bilateral TPA, which is anchored on the TAD, will give you expansion retention, because you need some sort of retention for these kind of expanders. So it does both the jobs in one go. This is how it looks like post-treatment. And if you compare, this is what I'm looking for. I'm least bothered about how the TAD works. I don't want to spoil the face. This is the main reason I'm distalizing. Sequence of fate, I always, and the key thing about it is always take an impression with elastomeric impression material, and always pour it in a dye stone. Do not take it in a plaster of Paris, because you need precision. If you don't get precision, most likely your appliance will fail, or it won't fit, and you have to redo the patient in already in an embarrassed situation where you can't place the appliance the first go itself. So make sure that some of the fine tuning needs to be done before you go ahead with your expansion and distalization. So this is how it looks like in comparison. So the next slide is class 2 division 1 bilateral open bite. Now this is the case that I was talking about with Dr. Mauro before I came in. This is an Italian girl where bilateral open bite, a very nice sweet one, but very specific about what she wants out of treatment. So she was not challenging, but very, how do you call it as, I had to up my game, if you call it that way. So we had to put a hybrid Hyrax expander in this, expanded her upper arch, as well as got some space to get the blocked out canines into place. Then I placed my 012 NiTi wires. I have not touched the lower arch yet. Now it comes the lower arch wires, leveling and alignment. And then I'm looking for how much of buccal corridor space I've created or narrowed it down. So it's very important that if you use an expander, make sure that you always have some sort of a leeway in order to give that beautiful smile or a broader arch form in these kind of cases. So there is always a comparison needs to be done, whether you made some justice of placing these TADs and putting that young girl into all these invasive procedures. Right. So I took my TADs out here, and I became more confident that on my left-hand side, the malocclusion, which had a little bit of end-on tendencies, I thought that I will correct it with elastics itself. I think I overestimated the elastics use. What happened was, it went on for almost 6 months, but the end-on tendencies never got corrected. And by that time, I already removed my TADs as well. Had I not removed my TADs, I would have popped the distalizers and I would have corrected it. So I had no choice but to put a infrazygomatic crestal implant in order just to get rid of that TAD, the occlusion that was endonish on the right-hand side. And this is how she looks like at the end of the treatment. Sequence of arch wire expansions over a period of time. We managed to get a good arch form for the patient, and this is how she looks like in comparison. Now the patient, as I said, she wanted everything to be corrected. Upper left-hand side central incisor, the composite got chipped. Then she wanted to get it done with the aesthetic dentist. She went for aesthetic corrections. This is how she came back in 2 years of time. Before, after treatment, after the composite corrections of the central incisors, and this is how she looks like in 2 years post-treatment. So what I'm trying to say is, if you require expansion, you need to pay attention to the buccal corridors, the black triangles, in order to give a nice, beautiful smile so that it fills the buccal corridor and gives a nice smile architecture as well. Now quickly move on to bimaxillary distalization. Now this is a bit more complicated cases in terms of the face as well as the teeth itself. Transpositions, or-retained deciduous teeth, and a missing lower incisors. In those cases, how much you can extract or not to extract, that decision I leave it to you. But in those cases, what I do is, I usually put a TAD which will allow me to further distalize it in the upper arch, and also buccal shelf implants in the lower arch. This is how it looks like, my design, in order to bimaxillary distalization of upper and lower arch. And if you can look at it, lower midlines are not matching because the patient has got one tooth less in the lower arch. This is how the sequence of treatment happens. And over a period of time, that gave me a lot of trouble, the transposition. I had to be careful about it in order to not to induce any root resorption while I'm transposing or correcting those. So I decided to keep that premolar where it was rather than correcting it back to its position. This is how she looks like after treatment. The midline has to be obviously not matched because she has one lower incisor missing. This is over a period of time, the follow-up. And I usually give, in these kind of cases, vacuum form retainers. It helps me to give some reinforcement to the already fixed retention that I've given to the patient. This is 4 years post-treatment. Hopefully, she will retain like this over a period of time. Now, adult distalization. Now, in these cases, again, these are quite mutilated. One premolar was already removed by the general dentist. I don't know for what reasons. And also, in the lower arch, the premolars were heavily restored. So what I did was I extracted the premolars on one side and I had to distalize it in such a way that I had to make a distalizer here. So the bilateral distalization will take place because I had to deal with one premolar less in the arch. And this is how she looks like over a period of time where molar relation seems to be in place of class 1 molar. Akshay, how long do I have? 2 more minutes? All right, okay. So this is how she looks like in retention. These are the appliance systems that I use. I don't change my bracket positions at all. If I require self-etching primers, I do that for 1 or 2 brackets that come out. Class 3s, en masse distalization or open bite. This is how it looks like. Borderline cases, I almost all the time put buccal shelf implants. Now in this one, the buccal shelf implant that I'm using is the Aarhus implant, which works well in the 15 minutes. Sorry, thank you. All right, so in this case, the buccal shelf implant really gives you a fair bit of an advantage if the patient requires some amount of distalization in these cases. Now, what I want to emphasize the fact is when you're doing an en masse distalization, especially the lowers, your second molar tend to have a rotational tendencies because they always are the posterior teeth, they are free end teeth, they do not get very well distalized and they always tip distally. So you have to give a counter rotation or a counter tipping bend in order to make sure that the second molar doesn't fling posteriorly. Otherwise, you will end up having a posterior vertically maxillary excess while you are distalizing these kind of cases. So this is how it looks like when you start the case and distalize a fair bit of an adult case. Now in these kind of cases, I'm incredibly fortunate to teach in a postgrad institute where my students tend to teach me more than what I could offer to them. So for me, teaching is more like a two-way street as when it comes to orthodontics. Let's see another case of open bite and distalization. Another case which is a mutilated case, a relapse case, already treated by an orthodontist, and then patient was not happy about it. Patient went to the dental council, and the dental council had a tribunal, and the tribunal decided that this needs to be transferred to a university set up, and this how this case ended up to me because I was one of the tribunal committee panelists. So when this case came, he was a very, very difficult person in the sense that he had lost all the faith in orthodontics. The orthodontist who treated kept on saying that this is very normal to have this kind of a bite, your teeth are well aligned, kept on saying it for 2 years. And then he went to multiple practices. I don't know what happened in those multiple practices as well. And then he ended up in the council, dental council, and the dental council made a review. And the committee said that this is a gross negligence. One needs to address this problem back again. So he comes into my clinic because I'm on that panel committee. So what I had to tell him that this is a surgical case. We can't be treating you with just dental appliance. But then having said that, after 2 years of telling him that, he had no faith in anybody else, including me. So I had to come to a point where I had to give him an invasive procedure which is not surgery, but I had to get his open bite corrected in such a way that he gets his bite proper so that he can chew proper from his front teeth as well. So in these cases, that is the only thing that comes into the picture, so that it kind of makes a merge of what camouflage line of treatment can offer and also what surgical line of treatment can do in borderline cases. But having said that, if you notice, the patient still has a fixed retainer. Now, he never allowed us to even remove the fixed retainer because that faith was already gone. So we had to really rebuild our faith, and he said that you are not supposed to remove a fixed retainer because I'm not sure about how you're going to treat this case. And let me see how far you can go, then I'll see whether I will allow you to take the fixed retainer out or not. So be it. So after several appointments, tats were placed both in the upper arch, in the lower arch. The whole idea was to kind of converge them, the diverged arches at the posterior segment. So if you are looking for open bite corrections, don't just put your tats in the upper arch. It's not going to solve your problem. It's not going to correct it. Even if it's corrected, relapse is 100% sure because some amount of intrusion of the posteriors of the mandibular arch must be taken into account while you are addressing your open bite of this magnitude. So this is how it looks like, and I tend to take in-between treatment. Now, I asked him to smile. That almost looks like a grin. He's still contemplating whether I'm able to pull this off or not. Because if you look at it, I just merely corrected his open bite to maybe half of it, and I'm yet to go with this. And he always said that my lower jaw is sticking out. I'm not sure about it. Let's continue doing it. Then I'll see whether, I'm confident enough, then I'll allow you to take my fixed retainer out. So, okay, so be it. Let's see what happens over a period of time. So I put buccal TADs, buccal shelf TADs, Aarhus implant. Bertie Melson did a fantastic job with the design of Aarhus. This has a bracket head itself, and it sinks very well in the buccal shelf. So my go-to implants for TADs in the buccal shelf is Aarhus 9 millimeters. That works very well because the buccal shelf, if you have a proper buccal shelf, the 9 millimeters is good enough for you to place those implants there. And they are quite sturdy because buccal shelf is quite cortical if you think about it. Right, so now the patient smiles, now the fixed retainer is out. If you look at the face, he is getting confidence in me. From the mid to the one that is on your far right, that's where the patient started smiling. That's where he started even greeting me or looking me in the eye. So now my job is now to kind of tidy it up. So I usually put settling elastics in the anteriors so that the open bite doesn't show up, and the buccal TADs continue retraction. Use power arms. Now yesterday Nanda Kumar was talking about power arms and how they make difference. I like those power arms because they give you a parallel line of force of action without intruding much. So if you can catch hold of those power arms, nothing like it. They usually give you a very parallel or a vector which is more in line with your occlusion rather than intruding those anteriors, and it will end up having further opening of the open bite. This is how it looks like after treatment. And luckily, I've not resolved any tooth there. My biggest problem was he was 6 years into treatment, 2 years of open bite. And also I told you open bite usually has got root resorption, so I had no faith whether those upper anteriors are going to remain like that or they end up having blunted teeth. And my registration will be a question mark because he is already coming from a council for another mitigation case, and I'm going into back to the rat hole. Right, so this is how it looks like over a period of time. Looks like the retention are held on. And this is how it looks like over a period of time. So he's quite satisfied with that. Open bite, bilateral intrusion is a must. The key takeaway is choose your case wisely, at least in the beginning. Not in all cases require indication for distalization. Explore all your treatment options. Third molars might be needed to remove. Negotiate, talk to the patient, additional costs. There's a GA cost involved. It's a slow and deliberate process. Do not commit to yourself, I'm going to finish it in 2 years. It's not going to happen. They're adults. Distalization is the most slowest process that ever orthodontics has seen. So I've written some papers in corroboration with what I think that you might be interested in. Please go ahead and read about that. I'm going to talk about the expansion or unilateral expansion in a case with canine impaction. Now this is an adult case. This is 19-year-old with a canine impaction. Now, the moment you see an impacted canine in a 19-year-old, people will think that why not extract it? Well, that is me. I don't like to extract things. I want to put things in perspective because I want that occlusion to be in place as well. So I gave an option to the patient that we need to expand, unilateral expansion. This is something I've been trying in my clinic for the past 5 years now, and I've got a fair bit of some amount of cases that I've collected. Probably I'll put it as a case report in one of the journals to say that unilateral expansions using a TAD is a possibility in those cases where you'll end up having some sort of a canine impaction. Now this is how it looks like. You actually need to exchange your nuts if you are doing a fair bit of expansion using a hex screw. Now this is how I changed that hex screw again so that I needed further expansion. The sequence of treatment, pay attention to the canine that gets enough space purely because of the expansion. I tend to use cantilever mechanics for canine disimpaction. It works well, and also make sure that you have put enough blue glue at the back because crossbite corrections are very hard to correct if the crossbite is not given enough amount of disocclusion. Now this is how it looks like in the sequence of events. Patient goes in for the removal of the C's and also the disimpaction of the canine with the gold chain. I don't remove my C until I want it. Make sure that you don't remove a C right in the beginning of the treatment because there's something called as regional accelerated phenomena that helps your treatment go faster. If you do your canine retained canine removal in the beginning itself, you might have lost that upsurge of cytokines underneath. So please make sure that there's a fair bit of technique that goes in that if the canine impaction is scheduled, then only you try and remove that C along with it. Otherwise, do not touch that because it might delay your orthodontic tooth movement. And it requires a lot of vector corrections. You can't just rely on one vector, and you keep doing that so that your expansion is held in place, your crossbite is held in place, and also the canine that has been impacted there, it comes back into normal without any signs of root resorption. And this is how she looks like after treatment. Before and after, and after 2 years of post-treatment. I think I did a fair bit of good job in getting that. And she was 21 years by the time the canine, and this is 2 years post-retention. So if you think about canine impaction, make your plans properly and pick your armamentarium. Otherwise, you will end up having a canine that is completely blunted, impossible to get it in line, and also you would have lost the chance of getting other teeth in correction as well. Now, we do have a lot of fun as well. This is my DMD graduation ball of 2023. I have a privilege of teaching both DMDs, undergraduation and post-graduation. This is the class of 2023 which graduated last year. This is one of my faculties, that's Mithran there, Prof. Ali Oikyu is one of my colleagues as well. And these are the Australian group where we have a consortium of teachers, we exchange ideas. Mauro is here, Marie Cornelis, Mithran, and other people from other universities. Now I don't have enough time, let me just run through it and then I'm going to stop it at that. Class 2 corrections. This is how it looks like in a class 2 correction. I usually use forces appliance on TADs. Why? Because I tend to eliminate the lower proclination which I get by Herbst appliance should I put it on the lower anteriors itself. This is how it looks like pre and post functional. After treatment, it looks like the retention has been taken into account. Few years into retention. Comparison, now you have to pay attention to that lower mandibular plane. So lower mandibular plane doesn't procline the way Herbst appliance or any functional appliance, if you anchor it on the lower teeth, that's the major cause for relapse. So in these cases, you don't get that relapse because you are not proclining the teeth. And this is the superimposition that has happened 4 years in treatment, in retention. I've written a paper on it. Please go through that if you want further information on these two. The last one, and we're going to end it, class 2 division 1 cases, which requires only tipping. Tipping is a case where you can only allow the upper anteriors to tip. I usually tend to extract upper premolars only, and then retract them and finish the case in class 2 molar relationship. So I need a TAD for that because it's a critical anchorage case. I need all that extraction space to be retracted for the upper anteriors. TPA, power arms becomes very essential because you can intrude and retract simultaneously and open the bite as well. This is how it looks like. Comparison, post-treatment, before and after, and probably one last case. Akshay? No? All right. Okay, so this is another case where adult case, a proclination of the teeth. I usually use A.J. Wilcock Australian wire in order to retract them with the power arm. It really gives you a good results because it simultaneously intrudes and retracts so that you don't have to worry about deepening of the bite when you're trying to retract it. Right, this is how it looks like over a period, 100% deep bite, traumatic bite. If you look at the upper anteriors, trauma on the soft tissues in the pre-treatment occlusal photographs has been eliminated. And this is the sequencing, how it happens. Comparison of pre and post. This is how he is at the end of the treatment. And let me just stop it at this. All right, okay. That's how it is, and I am sorry I have to rush because I don't have enough time. Thanks for listening to me, and one thing you have to realize that TAD is not a magic wand. TAD is not there to help you. You need to help yourself. Diagnosis is the key. If you really are into for TADs, think about it because it's an invasive procedure. I might like it, but I'm not a proponent of it. If there is a case that requires TADs to be placed, so be it. Otherwise, stay away from TAD. Thank you so much for listening.
Thank you, Dr. Narayan, for showing us good number of cases with your distalized